The global burden of illness and disease from illicit drugs is enormous. 20 million years of life lost to disability and premature death worldwide each year. There are around 37 million ICE, that's methamphetamine users alone, and according to a new book by 3 leading Australian drug researchers, doctors in particular aren't fully aware of the harms done by the various illicit drug classes. And some of these harms might surprise you. One of the authors of the Clinicians' Guide to Illicit Drugs and Health is Shane Darke of the National Centre for Drug and Alcohol Research at the University of New South Wales.
If you take a GP, I guarantee that any GP is very well versed on the effects of alcohol and tobacco. But presented with the whole range of illicit drugs, and it's constantly changing, the patterns of use and new drugs emerging, there was nothing that people could go to and say, what is the effect of psychostimulants on the heart, for example? And that was the gap we're trying to fill.
Well, let's start with psychostimulants. I mean, what are we talking about here? Ice, methamphetamine, is that mainly what we're talking about?
Yeah, in this country, methamphetamine, but also cocaine, ecstasy.
Now, I was talking to a cardiologist a couple of weeks ago, off microphone, and they'd just been on call for a major teaching hospital, and they were up all day and all night with young people with heart damage from drugs.
That's right. I mean, and that's one of the things I think a book like this can emphasise. Probably the single most major health effect of drugs like ice is upon the heart. You can develop quite accelerated heart disease, and for serious heart disease like cardiomyopathy within 2 years of actually commencing use. Young people, and I think many doctors, for example, would not be aware of that. We focus a lot, for example, on psychosis and violence and with ice, and that's true. That's absolutely true. But accelerated heart disease and the risk of heart attack and stroke is probably the major health effect of those drugs in young people where it shouldn't be being seen.
And are you able to quantify this risk? Because a young person taking up a drug like cocaine or ice might say, well, you know, if it's 1 in a million, that's fine, I'm going to take it. Is it 1 in 1,000? I mean, can you quantify it? I mean, you can quantify the risk of heart disease from smoking.
Yeah.
Can you quantify it from ice?
It's very difficult because it's unclear how many users we have at any one time, and you have to have things looking at the frequency of use, etc. We can say
it's one of the problems with it being illicit is you can't measure it.
Illegal drugs are invariably like that. You have hidden populations. But we do know some things. For example, stroke, which is something that, if you look at young people, strokes are very rare. But amongst methamphetamine users, the risk is 5-fold. And we recently did some work that showed out of all of the strokes amongst young people in this country, in Australia, 1 in 5 were related to psychostimulants, and almost all of those were methamphetamine, people taking methamphetamine and having a stroke. So I think the point really is that, as you say, young people aren't going to be thinking of heart disease and stroke, but they are real risks, and we have documented cases of people, you know, with cardiomyopathy within 2 years of actually commencing use of the drug.
So they get heart failure and go on a transplant list.
Precisely.
And what about relative to each other? So you're talking about methamphetamine, ice.
Yeah.
What about cocaine? What about ecstasy, MDMA?
All of those drugs cause hypertension, and that's the
high blood pressure.
High blood pressure, and that's the major problem. However, having said that, methamphetamine seems to be particularly problematic. It has a longer half-life.
Meaning it lasts longer in the body?
It lasts longer in the body, so the hypertensive spikes last for longer. And I think we need to be aware of this, that a drug like ecstasy, or MDMA, I think many people think of it quite benign, but we have documented strokes of young people and dying from strokes in young people after taking MDMA. There's no drug you can take that doesn't have harm. And the psychostimulants as a class, the major problem you're facing with all of those are things such as hypertension, heart disease, stroke, and also seizures. And there's also evidence, for instance, as we note in the book, for early onset Parkinson's disease associated with, specifically with methamphetamine.
What about dose and frequency of use? Can you relate that to that, or is it just, you know, bad luck? You're particularly susceptible, and after a couple of doses, you get hit with a stroke.
The thing about the psychostimulants is there doesn't seem to be an obvious dose response. People can take quite low doses and have a stroke. So when we look at the toxicology of fatal strokes,
It's a genetic lottery.
It would appear to be a genetic lottery. For example, you don't know if you've got an aneurysm, a weakness in an arterial lining in the brain. You may die at 90 of something completely different and that never burst. But you regularly take methamphetamine, or you take even once, that could put enough pressure on that artery that it bursts. So it's certainly more frequent use and heavier use is going to increase the risk. But the thing about the psychostimulants is there just seems to be more of a lottery.
So I'm not going to focus on cannabis during this interview because people have heard a lot of the issues with cannabis. Yeah. We'll come back to some of the new psychoactive substances, many of which are cannabis related, in a minute. But increasingly you're reading books about or hearing stories about hallucinogens, and hallucinogens being used for therapeutic purposes for psychosis and depression and so on. What's the overall picture when you look at the evidence for hallucinogens of benefits versus harms?
I think that the evidence at the moment of benefits are not at all well demonstrated. I think the evidence of harm of hallucinogens are very well demonstrated.
So in Australia we're talking about LSD, psilocybin?
Yes, which is psilocybins and magic mushrooms, LSD. They would be the main hallucinogens. We know those drugs are associated with an increased risk of psychosis. I personally have concerns clinically that one would prescribing a drug to address mental illness that is known to cause psychosis. Now, people say, oh, yes, it'll be in microdoses, but the problem with a drug like LSD is that it's so potent, they're all microdoses. I find it difficult to see a good argument for it, but let's see the evidence.
But when you actually look at the hallucinogen chapters in your book, the harms are small compared to the psychostimulants.
There's no doubt about that. I mean, each drug has harms, and the harms that they have they vary from drug to drug, which is one of the reasons you need a book like this. It's not that all drugs cause the same harm. There is no doubt that if you want to talk about a drug class that I think has, given its ubiquity and its potential for harm, the psychostimulants are serious concern. There are concerns with hallucinogens. They do have hypertensive effects, but it does not appear to be as great as the effects of the psychostimulants. I think a major concern with those types of drugs, of course, is intoxicated injury, which I think we always need to take into account, and the risk of ongoing psychosis and so-called flashbacks where people re-experience a psychotic state, which can actually, in some cases, not resolve.
I mean, one of the frustrations here is that people are producing new types of illicit drugs all the time. Sometimes they're not illicit until people discover they're there, then they're made illicit. But you say in this book that they're mostly related to cannabinoids. They're mostly cannabis-like drugs.
This is the class of what's called novel psychoactive substances. What's interesting about them is, I think one of the reasons we wanted to have a chapter on that is because something like 400 or 500 different sorts, and by the time we finish this conversation, another 100 will have been produced. And it's incredibly confusing. What we actually wanted to do was take them out and say, well, what are they? There seem to be the two major classes of that are synthetic cannabinoids and stimulants / hallucinogens. Now, the synthetic cannabinoids are probably the most common, and certainly they've been a major problem in countries around the world, an emerging problem, which a clinician is likely to see.
This is more than just a boost in tetrahydrocannabinol, THC. This is something...
This is a different drug altogether. These are different drugs. They're called synthetic cannabinoids. They act on the cannabinoid receptors in the brain. We don't know what else they act on, but I would say that they're probably misnamed in the sense that in every other way they look like a stimulant. They produce high blood pressure, they produce heart disease, they produce acute kidney injury, they produce psychotic behaviours. This is an example of someone using this, and we've just done some work on this, and one circumstance seems to be that people want to stop smoking cannabis, So they think, I'll move on to synthetic cannabinoids.
So it's like the methadone, they're thinking this is like a methadone equivalent.
That's exactly right. That's a substitute. But in fact, what they're moving over from is cannabis to a drug that's actually, despite that, looks nothing like cannabis. It doesn't have THC in it. There are a whole range of different substances. They're actually moving into smoking a stimulant.
And a much more dangerous territory.
Much more dangerous territory. And there's even now emerging liquid preparations of this drug. This has become a major problem with producing delirious and violent behaviour in, for instance, in the United Kingdom in prisons. Easy to smuggle in a drug like that, and it's causing a lot of trouble. Now, I think there's two things here. One, users need to be aware. This is not cannabis. And clinicians need to be aware that someone's coming in and saying, well, why is this person presenting with hypertensive heart disease? And think, right, well, they've been smoking synthetic cannabis. People might have heard of brand names. Brand names is probably a strong word, but Chronic or Spice. They're sold in small, like 3-gram packs. And I think one of the problems with a drug like that is, which is now illegal in our country, because it comes in a package with a label, with a brand name, it looks as if it's safe, and it's not. It's not at all, and it's not cannabis.
And finally, Shane Darke, treatments, and particularly the psychostimulants. My understanding is that there are no great treatments to get you off ice.
It's the major problem we have, like in Australia and really around the entire Pacific Rim, west coast of the United States, New Zealand, Asia. Methamphetamine has emerged to be probably the single biggest drug problem we have. And it, unlike other drug problems which focus in cities, it's spread throughout the country. We don't have a frontline drug to give people. You mentioned methadone before. If someone comes in with a heroin problem, one option is to give people methadone or buprenorphine, which are substitute opiates. There is no such drug, despite billions of dollars and decades being put into it. We don't have a frontline pharmacotherapy. The options then are really residential rehabilitation, and I think residential rehabs do a great job.
But it's not long-term and it's expensive.
It's long-term, it's expensive, it's not for everybody. It's a very difficult treatment population. People coming into a residential rehab with a heroin dependence are much more sedate, laid back. These people tend to be very wired and edgy. I mean, there are also some psychological interventions, cognitive behavioural treatment. I would suggest that all of these are valuable, but something like cognitive behavioural treatment, you're probably looking at people with less severe problems.
It used to be said that when you looked at the population of people who were addicted to heroin, if you could keep them healthy, 5% or so of them a year would give up of their own accord.
Yeah.
Is it the same for ice?
You know, that's an interesting question. We don't have that longitudinal data. We know that what you've said is true with heroin. In longitudinal work we've done, there are just some people that stay on. Ice is an interesting drug because one of the things that heroin does, the withdrawal syndrome, means that people seek the drug. Methamphetamine has a withdrawal syndrome, but it's nothing like the severity of the opioid, yet it's incredibly addictive. And particularly smoking it seems to be particularly potent. I think it's a very hard drug for people to give up. We don't know an exact figure on that, but I think what you've got to look at are cases of deaths. We're getting people who are dying from methamphetamine aged in their 60s. That would suggest that some people just can't give up. It's a very, very potent drug. If we'd have been having this conversation in the 1990s when talking about amphetamine, would have been about 5% pure. When ice came in around the turn of the century, suddenly you had a potent drug 50 or 60% pure. That's a whole different ballgame, and that's why you can see the addiction potential of a drug that's 60% pure is far stronger. And I think it is a difficult drug for people to give up. I think we need to recognise that. One of the things with all drug problems that we know is their chronicity. The idea that people just pull yourself together and stop using, well, if that was that easy, people would have done it, and it's not that easy. Ice is probably the single biggest treatment challenge that we face today.
Shane, thank you.
A pleasure.
Shane Darke is at the National Drug and Alcohol Research Centre at the University of New South Wales. Well, details about the book on the Health Report's website.